Hello, everyone, and welcome to the Parkinson's Foundation program On the Menu, Nutrition and Parkinson's. I'm Sarah Maldonado, Community Program Manager for the Parkinson's Foundation in the Southwest Chapter, and I'm so excited to be here with you today to bring you this educational program. This is my first in-person program, so I'm thrilled to be here with you guys here in the audience. We also have a large audience joining us on Zoom, so thank you all for being here today. For those of you who are new to the Parkinson's Foundation, welcome. We are the nation's leading community for people with Parkinson's, the people who love them, and all of those who are working to end the disease. With our presence in communities across the country and the globe, we believe in the promise of a cure and a better life today for those impacted by PD. The urgency of our mission really translates into what we do. To achieve our mission, we pursue three goals: ensuring better care for everyone with Parkinson's, advancing research towards a cure, and educating and empowering the Parkinson's community. We provide free resources, including our website at parkinson.org, educational book series, webinars, podcasts, a hospital safety kit called Aware and Care, our newly diagnosed materials, and of course, our toll-free helpline at 1-800-4PD-INFO. For those of you in person, we also have a table full of collateral, so please swing by there, pick things up. On the research front, we invest more than $10 million annually to study Parkinson's, what causes it, how to treat it, and ultimately how to cure it. I'd like to highlight PD Generation, which is a Parkinson's Foundation initiative that offers genetic testing and genetic counseling at no cost for people with Parkinson's. Participation can be done in person in some locations or from home through a telemedicine appointment and at-home cheek swab collection kit. We also want to highlight a study that you can participate in from your home. The TOPAZ study will test if a medicine can prevent fractures in those older than 60 living with Parkinson's. If you qualify, a nurse will come to your home and you'll receive a one-time treatment. You can call our helpline at 1-800-4PD-INFO to learn more. Before we begin, I'd like to give a huge thank you to our sponsors. Please, if you're in person, go visit our table, check them out. But I'd like to thank Supernus, Boston Scientific, Merz Therapeutics, Kyowa Kirin, AbbVie, and Medtronic. All right, now we're going to jump into today's topic, On the Menu, Nutrition and Parkinson's. I'd like to introduce our speaker, Dr. Mari. Dr. Mari is the Ruvo Family Chair and Director of the Parkinson's Disease and Movement Disorders Program at the Cleveland Clinic Lou Ruvo Center for Brain Health and Adjunct Associate Professor of Neurology at Johns Hopkins University. Dr. Mari is the Chair of the Movement Disorder Society's Telemedicine Study Group, Co-Chair of the Parkinson Study Group's Motor Features Working Group, and serves as Associate Editor of the Parkinsonism and Related Disorders Journal. Previously a full-time faculty at Johns Hopkins University School of Medicine, Dr. Mari was the director of the Movement Disorder Clinical Fellowship Training Program, the DBS Center, the Parkinson's Foundation Center of Excellence, the Dystonia Center, as well as the Parkinson's and Movement Disorder Center. Since his 2017 transition to the Ruvo Center, Dr. Mari has led the Cure PSP Center of Care, Lewy Body Disease Association Research Center of Care, and the Cleveland Clinic's Parkinson's Foundation Center of Excellence. Dr. Mari has authored or co-authored several book chapters, patents, over 100 published abstracts, over 120 peer-reviewed papers. He has received uninterrupted external research funding for nearly two decades, has served as a PI or AI on many clinical studies in the area of Parkinson's disease and other movement disorders. It is a pleasure to have you with us here today, Dr. Mari, and on that note, I will pass it off to you.
Thank you so much, Sarah, for that introduction, and I also thank the Parkinson's Foundation for the invitation and picking this topic, which is so important to all of us. And I'm particularly pleased that we have now on our way to resume in-person programs, and this is the first one in over 2 years. Cleveland Clinic itself is still not letting us do in-person programs, but it is possible to do it with the help of the Parkinson's Foundation, as it's their program. And again, I'm thankful that I could be the speaker for this program. Hopefully, we can address concerns and important science and knowledge relating to nutrition and diet. There are still more questions and answers, but I'm very happy to go through the knowledge and the evidence that we do have on this topic, and hopefully we will have time in the end to answer questions, and I'm pretty sure you have questions on this topic. And this is also our first hybrid program. Hybrid program means that we are very happy to have you in person, and we really see the value of in-person programs. But at the same time, this program is also live cast on the web, so people who are tuning in are able to enjoy the program live in real time, and hopefully they will too be able to ask questions. So with that, I would like to start with the program overview. Today, we will talk about two main parts. The first part is the fundamentals, some basic information, some unquestionable information regarding nutrition and diet. Some of the important things are part of that. It is not boring, it is not that simple, but it is very important. So I think we should start with that. I know that most patients who ask me about diet and nutrition in the clinic are not interested in this part. They are interested in the more advanced part as to how we slow down the progression of Parkinson's disease, how we prevent certain symptoms popping up later. And so that's kind of the neuroprotective or neurodegenerative delay or preventative type of interest in diet. Now, we don't have a whole lot to offer on that, but that will be the second part of my talk. So as far as the fundamentals, I would like to say first that eating healthy, generally healthy, and let it be the DASH diet or the MIND diet or anything that is generally based on principles as guided by anyone, even if you don't have Parkinson's disease, those healthy eating diets and advice should apply first, and will be probably helpful to you. If you have comorbidities, you have high cholesterol, you have diabetes-related neuropathy, osteoarthritis, and the list goes on and on with these chronic disorders, you will not benefit from your Parkinson treatments as much. All these comorbidities will confound and make your experience with Parkinson's and Parkinson's symptoms worse. So living healthy, regardless of Parkinson's, and just following general advice will help your Parkinson's too. Because if you have less of an impact from these comorbidities and other medical conditions, then your Parkinson's will be better. So that is the first point that I wanted to make. And that's sort of further expanded in this second point here, that paying attention to what dietary needs of these other chronic conditions that you may have will help your Parkinson's. The next point that I'd like to make is that while there is such a thing as eating healthy, and it's fairly general, if you will, there is also a need to pay attention to your personal needs and individualize dieting advice accordingly. Getting a nutritionist consult you at some point with your Parkinson's disease, hopefully in the earlier stages, is a very, very good practice, because they can assess you for all these comorbidities that I mentioned, assess your age, and all your dietary needs will be evaluated in the hands of a professional that knows that. You heard from Sarah about the PD generation, this wonderful initiative that allows both free genetic counseling as well as genetic testing for certain Parkinson-related genes. Well, some of you might have heard about the 23andMe, which is a commercial, affordable genetic testing platform where you can, well, it was primarily intended for assessing your roots and connecting with family, etc. So there is this ancestry component, which is the cheaper part. I think it's $100. But then you can also add another $100 some genetic risk gene evaluations, and many of those will be relevant to what you should eat and what you should look for. I found out, for instance, from that I had a lipid metabolism issue, which makes me more at risk for liver fatty liver steatosis. And that helped me adjust my diet. I had not had any knowledge about that. And there are many other risk genes or other mutations that you can find out which can help adjust your diet accordingly. The point being is that what works best, or what may be the most ideal diet and nutrition for you, could depend on these individual genes, individual and customizable advice. So keep that in mind, that there is no one size fits all, a diet that will work for everyone. And I will discuss a little bit more on the fundamentals with regards to how you should eat with respect to your medication timing and other aspects of your disease. That will be still discussed on the fundamentals in the next several slides. On the other hand, there will be a part of today's talk which will try to give you some information regarding what is beyond the fundamentals. And the reason why I use the terminology beyond fundamentals is because much of that is not a agreed upon consensus knowledge yet. There's a lot of hypotheses, ideas, suggestions, and many of them will probably pan out in further studies and additional research that we are doing, but a lot of this part is not fully established. So I just wanted to make that clear for full disclosure, that, and I will point out what's not known and what's hoped or suspected. It's still an important discussion. It still belongs to the nutrition part. And so how the pathology and etiology is affected by what you eat is a big question. A lot of interest in it, but again, little as far as established and proven information. I got this slide from the foundation just as a sort of introduction to the next slide, because there are some. I mentioned the individualization, how it's important to take into account the personal clinical characteristics and features and comorbidities and a lot of things with regards to the person when we come up with certain dietary advice. One of those factors would be the staging of Parkinson's disease. There may be different rules or different basic advice that should be applicable or considered depending on which of these stages an individual may be in. And these are also referred to as the Hoehn and Yahr stages. Sometimes we also use the modified Hoehn and Yahr staging, which is slightly different from the one that you see here, including stages 1.5 and 2.5, which were not part of the original staging here. And these are the descriptions of each of the stages of 1 through 5. By the way, when I show this slide and discuss the staging of Parkinson's disease, without a doubt, the Hoehn and Yahr staging has been around for 50 years, and it has been one of the gold standards of talking about where somebody is in Parkinson's disease. Having said that, it has a lot of limitations and flaws. It's not a linear scale. It's not that you spend a certain number of years in stage 1 and then stage 2. It does not necessarily advise us regarding prognosis. and it does not necessarily advise us with regards to treatments or practical matters. Staging is much more practical in the cancer domain. Cancer types and stages are very meaningful as to what treatment should be used or should not be used. We can't really say that with the Parkinson staging. So when I show you the dietary and nutritional relevance of the staging, you take that with a grain of salt, because patients can have very different needs and problems regardless of the stages. But having said that, this is what I proposed. In stage 1, the patients, when they were just diagnosed and in the early stages of Parkinson's disease, many times they don't even need medications at that point. Medications or other treatments in Parkinson's disease, as you know, are purely symptomatic, which means that they do not intend or able to change the course of the disease. They are just answering to certain symptoms. And if somebody doesn't have disabling symptoms in the early stages, they don't need medications. Maybe they benefit from a little therapy and just exercise. It is generally, that generally means that at that stage, there is no specific dietary advice. Again, I mentioned earlier that the beyond fundamentals part speaks to how we can prevent maybe the pathology, how we can help the neurodegeneration slow down. Not much clear proof there. I will show you what we know, but that would be applicable to the healthy eating at the stage 1. On the other hand, when you move to the stage 2, most patients will be on some medications, and ultimately everybody will be on carbidopa, levodopa. Levodopa is still the most potent medication, and one that has the most favorable overall side effect to motor benefit ratio. So there's just a question of time that everybody will take that. So many of the patients who are in stage 2 will be at that point. But the stage 2, it would be very uncommon or unusual for somebody to reach the point where they have these so-called late motor complications of levodopa therapy. So the one thing that comes up very often with levodopa is nausea. And so it's a peripheral dopaminergic effect, and it is very common, especially in the early stages when levodopa is started. And again, that's typically stage 2 when we start levodopa. So what do you do about that? Well, the good news is that nausea or gastric upset or sometimes even vomiting will not stay long. It is almost always a temporary situation which with time will take care of itself. Now, it could be quite problematic and it could persist in some patients, in the minority of patients. So what are we going to do about it? So one thing that you can do about it is extra carbidopa. The carbidopa, which is part of the carbidopa levodopa, is something that stays out of the brain and just makes sure that the levodopa actually gets into the brain. So the carbidopa's role is to inhibit the dopa decarboxylase and make sure that the levodopa in the form of levodopa will make it to the brain. If it doesn't make it to the brain and it gets converted to dopamine before it makes it to the brain, then it will cause nausea. And so sometimes the levodopa carbidopa pill doesn't have enough carbidopa to ensure that the 100% or the maximum blockade of that dopa decarboxylase occurs. So that is when we need to add a little extra carbidopa, and that way the nausea will go away. There are other ways of handling it, but one with regards to the nutrition, one very important aspect is how do you time the levodopa relative to your meals? Almost always we start levodopa at the 3 times a day schedule, so we tell people let's just take it at breakfast, lunch, and dinner, so make it easy to remember. But then what happens is that if you take levodopa on an empty stomach, then it will be much more likely to cause nausea. On the other hand, if you take it on an empty stomach, much more of it will be absorbed, and not only that, but it will be absorbed at a more reliable and more predictable fashion. When you take it with food or after food, not on empty stomach, then the nausea will be less, but then less of it will be absorbed, and the timing of the absorption will be less predictable. So that's a trade-off. How that trade-off plays out in the context of the staging of Parkinson's disease is as follows. In the early stages, including stage 2, these late motor complications are not happening. The brain still possesses a fairly good so-called dopamine buffer, which means that it almost doesn't matter if the orally provided levodopa gets into the bloodstream and absorbed there quickly or not so quickly or anywhere in between, quickly and slowly, because ultimately the buffer in the brain will be able to pick it up at whatever rate you're providing it, store it, and then release it at a physiological rate. So the timing of the absorption has little impact in how levodopa helps people. In other words, on this trade-off that I mentioned, if somebody's nauseated, we err on the side of giving it with food, even if it doesn't get absorbed fully, even if it doesn't get absorbed quickly, and even if it's not a clockwork and very predictable, because those are little impactful in this stage. That equation and the trade-off will change as the disease progresses in the stage 3 and beyond, where these motor complications will include wearing off. And because of the wearing off, it will be much more important to find a way to get the levodopa in there more reliably, more quickly, and in full amount. And therefore, we will advise to take it on empty stomach, because that's how we know that it will be getting in more quickly, more reliably, and more fully. And therefore, in this trade-off, we will err on the side of advising empty stomach taking or taking the levodopa on empty stomach. And also, as I mentioned earlier, the nausea problem by this stage almost always completely dissipates, so we don't have to worry about that. So that's sort of the nutshell as to, because it always gets discussed in clinic, and it does feel a bit controversial that sometimes we say that take it with food, and sometimes we say take it on an empty stomach. Some people say one thing, and this is how you resolve that sort of apparent controversy. And to some extent, this applies to protein content. That is a bit of a controversy on its own right. Some people say, oh, don't eat protein because that will interfere with the levodopa absorption. At the same time, other people will say, eat a lot of protein because that's good for Parkinson's, that's good for your diet. And one of the tissue that tends to be lost in Parkinson's disease is the muscle tissue, which is protein. And by the way, muscle bulk, muscle tissue, is the best metabolically important tissue of the body. So losing that is the worst thing that can happen to you. So how could you advise to restrict protein intake when that will lead to even more atrophy and loss of muscle tissue? So the controversy is eat more protein versus eat less protein. Which one is it? Well, again, it depends. On the one hand, just like I said earlier, in the stage 1, 2 stages, where there's still a lot of that so-called dopamine buffer, you don't have to pay attention to the protein intake interfering with levodopa. It's a non-issue. What is an issue is that you need to eat a lot of protein because that's good for your body. It is true that the protein, high protein content may interfere with the levodopa absorption. But again, at those early stages, it's relatively a non-factor, because ultimately the levodopa will get in, and if we need to give you more to get the benefits, we'll give you more, and the dopamine buffer will pick it up, store it, and release it continuously in an even fashion, so you would not have any worsening of your motor fluctuations or any of that because of that still persisting and functional dopamine buffer. Again, as we advance through these stages that you can see on the slide, into the stage 2, 3, and beyond, that will change because you will have wearing off, you will have motor fluctuations, and therefore any interference and inconsistency and unpredictability of how the levodopa gets into the bloodstream and eventually to the brain will be impairing your function a lot. So in other words, when it gets to that stage, it is true that you would have to restrict the protein intake around the time of levodopa because of that. At the same time, you still have that need to eat a lot of protein because that's good for you otherwise. It's good for your body. So how do you handle that? Well, the way to handle that is that you try to avoid high protein content food and intake during the time in the daytime of your levodopa dosing times, whereas focus and concentrate the large protein containing meals to the end of the day. A big shrimp salad or tuna salad or fish or steak. Take it to the late part of the day with the supper or dinner, and that way it will slow down the levodopa absorption overnight, but overnight your gastric emptying is going to be less variable, even if you have gastroparesis, which is common in these later stages of Parkinson's. Even if you have that, overnight the variability will be diminished, so it will be more or less even emptying. It will be slow emptying, but that's good. The protein will withhold some of the levodopa from being absorbed or delayed, but that's okay too, because you are sleeping, and then at least that slow delivery or absorption will provide you coverage over those hours of sleep. So in other words, the controversy about protein is summarized as this. In the early stages of Parkinson's disease, when you don't have motor fluctuations, you can just eat protein as much as you want, and you should, because it's good for you, without regard to the levodopa dose timing. When you develop motor fluctuations, on-off fluctuations, and wearing off at the later stages of the disease, then try to avoid protein, large protein-containing foods around the levodopa dose timings in the daytime only, whereas try to concentrate and time your high protein-containing foods to the end of the day. So hopefully that was properly covered. With that, I would like to move on to the next sort of fundamental topic, which comes up in clinic all the time, as to should I use natural sources of levodopa? How come we don't use that? And of course, the question regarding some of these plants come into play. So Mucuna pruriens is the most well-known herb that contains levodopa, but there are others. And just because we have this natural attraction to naturopathies and natural sources, while levodopa is obviously available in a lot of medications, some people would prefer a natural source for levodopa. My advice, don't do it. And there are many major concerns. I'm sure that there are lots of naturopaths and others who would like to market it and would like you to try that. But the reason why I don't recommend it is as follows. First of all, the amounts of levodopa is less than certain in these products. We don't know exactly how much. The FDA requires very clear and accurate regulation as to what the amount of medication or the active ingredient, such as levodopa, may be in medications. No such regulation or certainty exists when it comes to these natural supplements. And then there is a potential danger because there is this myth or misconception that says that if it's a natural product, it can't hurt you. Where it can. And there are many examples of naturally occurring toxins, including botulinum toxin, which are could be very harmful, and they are naturally occurring. So be careful there. The other thing that I would like to emphasize, I mentioned earlier that the purpose of the carbidopa, which is otherwise biologically inert, it doesn't do anything, it doesn't have any biological or pharmacological effect that's relevant to Parkinson's disease or otherwise, it's there with the levodopa in order to block the dopa decarboxylase. And that is necessary for the levodopa to make it to the brain where we need it. Now, if you don't have that blockade, And there are other dopa-decarboxylase blocking agents besides carbidopa in Europe and other parts of the world. They sometimes use benserazide, and there are still others. Anyway, without that, without a carbidopa or benserazide or any sort of dopa-decarboxylase blocking agent, the levodopa very likely will not get into the brain. And if it doesn't get into the brain, well, as we discussed earlier, it will be converted to dopamine in the periphery outside of the brain, and then it will cause nausea, gastric upset, and many other side effects, low blood pressure. The list is very long for what the peripherally released dopamine will do to you. It's not, none of them is good. And so when you use levodopa in a natural product without any of these dopa-decarboxylase blocking agents with it, then the levodopa is not going to make it to the brain. It will be converted to dopamine outside of the brain, and it will cause side effects at best, but it certainly won't help your Parkinson's. So that's another important part. Now, having said that, if you use excessive amounts of levodopa without carbidopa or anything, you can overwhelm the dopa-decarboxylase, and that's what happened if you see the movie Awakenings, where Robert De Niro played a patient with this Economo disease or encephalitis lethargica patient with a Parkinson-like illness, and Robin Williams played the doctor who used heaps of levodopa, which was 50 years ago when levodopa was discovered, and they didn't use any carbidopa or anything, but they had to use literally spoonfuls amount in order to overwhelm the dopa-decarboxylase. But the amounts that are available in herbs, etc., will be obviously too little for that. So with that, I'm going to now move on to the second part of the presentation, where we discuss some of these beyond fundamental issues. And of course, one question is, can nutritional supplements make a difference? And there is a strong suggestion as to why that is. So there are, I mentioned multiple times earlier that we have to take anything about these with a grain of salt. And the reason is that what we currently trust in terms of evidence and information usually comes from the so-called RCTs, the randomized clinical trial, the controlled trials. So what are those? Well, in clinical science, a lot of things can do a lot of effects, and in order to sort out what does what, you need to have a controlled way of looking at that. And a controlled way is that you know some factors that might affect your results, and you control for them. And one of the controls is a placebo control, where you randomize individuals into different arms. Usually there's a placebo arm and there's an active treatment arm. The active treatment arm could be multiple, could be several different cohorts with different doses of a medication, for instance. Or it could be an active control where the patients are randomized into a group where they will know and they will get a known medication for their condition. The bottom line is that it has to be prospective. You can't just go back to the chart and figure these things out. You have to make it prospective, have a hypothesis as to what you need to study, and have a study protocol or design in which you test your hypothesis, and then follow through and make sure that the protocol is fully executed. Now, the results of such RCTs will be trusted as the best available evidence for the question in your hypothesis. And there are also obviously failed trials where we don't get that question. You have to make some statistical assumptions before anything starts, before you actually enroll any patient in these clinical trials, and then those statistical assumptions could be sometimes incorrect. Now, all of that, and then executing the trial, will take a lot of time, a lot of effort, a lot of money. And that's part of the reason why we are not seeing a whole lot of randomized controlled trials in the nutrition and nutritional supplement world. who has that money and who will have the ability to have any sort of return on that investment. For usual, typical classical pharmacotherapies, there is usually a sponsor, and they will take the chance of investing this large amount of money that's necessary to run a randomized clinical trial. And if they are successful, then they will be able to get some significant return. And that's kind of the business model in the pharma world. That business model does not apply to nutrients, because what happens in the case of nutrients, there is no patent. There is nothing that can be specifically charged anyone. Let's say the information is positive or the clinical trial is very successful. Well, anyone can sell it, and anyone can go and replicate that vitamin or that combination of vitamin and nutrients. And in the end of the day, that money will never produce any return. Now, there are some ways around it, and of course it's important to talk about that too. Public interest dictates that we know more about nutrients and nutrition, and so there should be some public investment in this, and there is. The NIH, the National Science Foundation, some of the foundations like the Parkinson's Foundation and others will certainly invest in that in appropriate studies, and it is happening, but you're not going to see as great investment as pharma companies can do where it's part of the business model. So a few items that I put here on the slides as to what so far has been learned, and it's relatively established that B vitamins have an antioxidant effect, and especially B3 vitamin, niacin, not just in Parkinson's disease, but in other neurodegenerative disorders, has been accepted as having that effect, and therefore we can make an assumption that it can have the potential of slowing neurodegeneration. When I say it can have the potential, I was wording it very cautiously to say that it's not actually proven that way, not in a randomized clinical trial, not in a group of Parkinson patients. And the other problem with putting it into a clinical trial is that there could be some washout effects in which part of the study cohort or study population is particularly susceptible to a certain nutrient or vitamin. And the other 90% or the other 80% is not. And then if you don't know which 20% and which 80% and put them all in one cohort, you will lose your ability to detect an effect. And so that is another difficulty, that we don't know enough about how to stratify Parkinson patients within the whole cohort. Most of the studies that are being done use clinical diagnostic criteria where you have certain clinical signs, but that doesn't necessarily mean that you have the same genes or genetic abnormalities or molecular abnormalities that caused Parkinson's disease in the first place, and we don't know which one. And so if you just use the clinical diagnostic criteria to approach a cohort, we might lose a very potent effect for that washout. So we need to understand at an individual level much better what causes Parkinson's disease before we can resolve this puzzle. The same is true for some of the other ones here, and I left off an important one, which is creatine. Creatine monohydrate is a supplement that is relatively cheaply available, and it is certainly proven that it helps muscle metabolism. At the same time, its effect in slowing down Parkinson's disease has been unsuccessful. There was the largest clinical trial ever done in Parkinson's disease actually is on creatine, the LS1 or NET-PD LS1. NET stands for Neuroprotective Exploratory Trials. It was a public investment. It was done by the NIH, and the largest clinical trial to date where 1,740 patients were enrolled in 50 sites. And again, it was unsuccessful. Creatine showed no benefit relative to placebo in slowing down the progression of Parkinson's disease. We don't know why that is, but one thing for sure, creatine is helpful for the muscle. And we talked a lot earlier about how the maintenance of muscle health is critical in Parkinson's disease. It helps you move better too, because if your Parkinson's disease attacks the circuits in the brain that control movement, the signal that is sent out by your brain and the motor system to the muscles will be flawed, will be erroneous, and then your movements will be compromised because of that. If your muscles are not perfectly healthy and have their own metabolic challenges and don't respond to the faulty signal, that compounds the problem. On the other hand, while the faulty signal will be not fixed, if you have a perfectly well kept and maintained muscle with a healthy metabolism, it will not fix the problem in the brain, but at least will not compound it further. And a healthy muscle will make you able to do the best out of what you have, because the muscle problem will not add to the brain problem, if you will. So I should have put creatine on that, and I do recommend that in clinic. Now, we didn't, there is a limited time, of course, and I don't know how much time do I have left? As long as I need. Oh, that's the first time I heard that here, because Paul puts these things on in front of me sometimes, and it's always read. But anyway, the bottom line is that with regards to the microbiota, tremendous amount of research is going into that. The issue is that we don't know how Parkinson starts exactly, and certainly we don't know that at an individual level, but we know a little bit about it at the group level. And so one interest focus has been the microbiota, the flora, the type of bacteria that populate our gut. And what happens there is that at least certain patients, and we don't know exactly the proportion of them, will have probably the Parkinson starting in the gut, actually. And it could relate to the altered flora, the microbiota in the gut. There have been studies that demonstrated that in the enteric nervous system, the nerve fibers, which are in the wall of the gut, showed the synucleinopathy, which is the pathological hallmark that causes Parkinson's disease, bringing down the cells in the brain through neurodegeneration. The same pathological process was found in the gut, in the enteric nervous system, in samples that were taken years before the individual developed Parkinson's disease. That pathological process, the synucleinopathy that can start in the gut, is blamed by some people by the altered microbiota. And further, there is no question that once you do have Parkinson's disease, there is an altered microbiota in the gut. And it is partially related to the fact I mentioned gastroparesis, which is the slowing of the stomach, peristalsis. The same thing applies to the intestines as well. And that's why we have constipation very, very commonly seen. All of these are very important in taking into account in Parkinson patients. I should say, though, that I mentioned earlier that individualized approach is important, and it is, because not everyone has constipation, for instance. So you will say, well, why are we talking about constipation? I don't have that. Well, that's what I mean by individualizing to the patient's needs. In fact, some patients have diarrhea if they are taking entacapone, for instance. So these are advice tidbits that I'm providing here that will need to take, they will need to be taken into account with the individualization and customization in mind. I also wanted to tell you a little bit about the so-called MIND diet, and on this slide I have to give a little disclosure that I have been an advisor to NeuroReserve, which is a company that makes the Relevate supplement. So I just wanted to make sure that I'm not recommending this. The reason I use this slide is more for this pyramid, where the diet is the foundation of it. And the MIND diet is something that takes advantage of the Mediterranean diet, as well as the DASH, which stands for diet for hypertension. And so there is this wording of intervention for neurodegenerative delay. Again, remember I said multiple times that there is no smoking gun there. There is no absolutely rocking evidence that the MIND diet, which relies on 10 ingredients, including grains, whole grains, fruits, vegetables, which you should have at least 3 servings of, and then 1 or 2 servings of beans, poultry, and fish every week, and so on and so forth. So the MIND diet is the best we have as far as dieting advice is concerned at the moment, and there's more research necessary to really establish how much it helps. And I think that one of the caveats there as to why we haven't established that better already is because individual patients' needs and makeup and including their comorbidities vary very much from one person to another. So how much it helps any individual is very hard to tell. We would need to characterize each individual from the metabolic standpoint, from the clinical standpoint, from the genetic standpoint, in order to better refine and make our sort of prognostication a bit more accurate. However, I would also like to say that the general idea of the MIND diet is certainly not going to harm anybody. It cannot hurt, and it might help. And of course, these supplements should take into account some of those vitamin-related and other advice that I went through earlier. I would like to point out the 2 references here, which relate to the Mediterranean and the MIND diet. These are relatively small studies, and my colleague, Dr. Alcalay, is also very interested in genetic research. He was at Columbia University, recently moved back to Israel. He's from Israel. And this is an excellent paper in movement disorders, about 10 years ago, though, and there's, as I said, more work needed to be done. And there's a more recent paper from Dr. Pinky Agarwal, who worked on the MIND diet in this population-based study. So both of these studies are very important, from Dr. Roy Alcalay and then Pinky Agarwal, that I recommend. But I think they raise more questions than they answer, and so there's certainly more need to invest in this. And I'd just like to highlight the Parkinson's Foundation, because the Parkinson's Outcomes Project, or Quality Improvement Initiative, has definitely an interest in furthering the understanding through the longitudinal following of individuals and tracking their clinical features, adding on what they do and why they are different from one another. So that's a very important resource of a natural history protocol for understanding Parkinson's disease better. So, by the way, that picture took off the select nutrients. It says target pathological mechanisms at play. But anyway, the next level, which is even beyond fundamental, is how we're going to be able to do the customization. We don't even know how to customize diet necessarily at every level for the fundamentals, the first part of my talk, and we know even less in terms of the second part, where we are looking for nutrients and diet and supplement advice that can perhaps slow down the progression of Parkinson's disease. As I said earlier in the talk, all of our conventional treatments, pharmacological treatments, neurosurgery, etc., all of that is symptomatic. So we haven't even figured out a medication that can slow down the progression of Parkinson's disease. And figuring out anything from the supplement, vitamins, nutrients, and diet side is going to be a step beyond that. So before we get to this point, we will have some neuroprotective treatments that at least are shown to be effective, even if in a subgroup of patients. So there's a lot of interest in genetics, and that's also motivating the PD generation effort. But a lot of people believe that the rare but important genetic variants of Parkinson's disease will allow us an opportunity to identify molecular targets, because we know what the mutation is, we know what gene is bad, we can figure out what the product of that gene is, and then develop an idea in targeting or developing targets based on that understanding. And so obviously once we have the ability to do that, we can learn a lot from that, apply that to many other targets and eventually to nutrition. And I believe that was all I had for today. And I know that it was a lot of information. It was technical here and there, but hopefully we can further explain and discuss all that at the Q&A panel discussions. Thank you so much.
Thank you so much for that wonderful presentation, Dr. Mari. For our online audience, please feel free to submit a question by clicking on the Q&A icon on the bottom black banner of your viewing page. For those of you in person, we did include Q&A sheets in your folder, so please feel free to write your questions on there. Just flag down one of our volunteers. They'll grab it and pass it up to me on the stage, and we will do our best to address as many of those questions as we can at the end of the presentation. So in addition to the information you just learned about nutrition, we hope you all know about the incredible benefits of exercise. So before we jump into our Q&A, we're going to take a quick movement break. You will be using the chairs that you're sitting in, so we encourage you to stand up, push your chair back a little bit, give yourself some space, and follow along. We'll be back in about 12 minutes for our Q&A.
Today's fitness focus is cardio, which I'm going to show you how you can do in sitting this whole segment. Props that you'll need include a ball, or you can use a cushion, but you're really going to energize this with me. So I want you to sit nice and tall, come forward in your chair, and use the bottom of the chair or your armrest for support as we start to warm up those legs. I want you to take your left heel out and bring it in, and opposite side and bring it in. Keep going out and in, and try to lift that heel up and off the floor. Stay with me on this tempo. We're just warming it up. You'll notice we'll go into higher tempos and lower tempos. We're going to get the arms involved as well. Keep this going. You've got 3 more sets before we add the arm and opposite arm to the leg, reaching overhead. In 2, you've got this. 1 more time. Okay, so left leg, right arm up, and switch. Keep going. Kick out, arm up and in. You've got this. Try to move together. Opposite sides. Give me 5 more sets. Keep going. You've got 4 before we focus just on the arms, moving them big. Keep it up. You've got 2. Push up. Last time. And stop those feet. Sit tall. Arms are down. Think of an upside down V. And then I want you to flip it. Take it down and up, like you're chopping right through the air. Keep this going. Really exaggerate the stops and the starts of the motion. You've got 5 more. Keep this up. In 4. Nice work. Last 3. And up. And 2. And up. 1 more time. Up. Arms come down to the seat. Hips forward. Take 1 foot out and in. Other foot out and in. 2 more times at this pace. 1 more set, and then we're going to pick it up. Out, in, out. Let's try to pick it up. You go out, in, out, in. 5 more sets, and we'll add a same arm reach. Keep this going. You have 2 more sets. Nice work. And 1 more set, same arm reaches. You go reach out and reach out. So same arm and leg going out to the side. Give me 5 more sets. Keep going. You have 4. Keep it up. Last 3. Nice work. Final 2. Keep staying big. 1 more time each side. Hands to the seat. Hips come forward. Left heel is going to tap front, tap the toes back. So heel and toe, hopping over something imaginary on the floor like a hurdle and bring it back. Tap it front, bring it back. I really want you to exaggerate it and pull it back. Knee goes up and over as the heel follows. You've got 5 more before we march in place. In 4 and back. You have 3 and back. Final 2. Keep going. 1 more time. We march in place. You march, 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 march for 10, 9, 8, 7. Keep your back tall. Here's 4, 3, 2, and stop. Hands down. Chest lifted. Right leg is going to work now. Heel forward, toe back. Tap heel forward, toe back. Think up and over that hurdle and back. Keep it going. Up and over and back. You got 5 more. Up and over and back. 4 more. Up, over and back. Here's 3. Over, back. Final 2. Over, back. 1 more. We march in place. March, 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 march. You're doing great. Take a deep breath here. Keep marching with me for 5 and 4 and 3 and 2 and stop. Hands to seat. Hips come closer to the edge. You're going to go out with one foot, out with the other, in and in. Continue that slow. Out and out, in and in. One more time, slow. Out, in, so you can stay at that pace or speed up. Go out, out, in. 5 more sets, and we add a same arm reach in 4. Bring it in. Here's your 3. Bring it in. Final 2, and in. 1 more time. We're going to add that reach. Out, out, in. This is where it gets tricky. Try to stay with me. Just keep both arms and legs moving and try to power it up with that reach. You've got 3 more sets. Keep going. Final 2. You've got this. 1 more. All right. Sit tall, arms down, hips to the edge again. I want you to tap 1 foot out and reach to the opposite side. Okay? Let's do that again. You're going to tap out and reach and come in. Tap out and reach and come in. Keep it going and back. You need to be closer to the edge of your seat for this. Big tap and reach and back. Tap and reach. 5 more before we switch sides and back. Here's your 4. Come back. You got 3. Pull it down. Last 2 and down. 1 more time. Sit it tall. Take that right leg out. Right arm reaches. And pull it in. Reach out. Pull it in. You're doing great. Reach out and in and out and in. 5 more. Reach. Pull. 4 more. Reach. Pull. Last 3. Reach and pull. Final 2. Reach and pull. 1 more. Reach and sit it nice and tall. Heels go up, down, just those heels. Keep that motion and get those arms to go up and up with the heels like you're jumping rope. Keep it going. You got 5 and 4 and 3 and 2 and 1. Now jump those feet, add those arms. You got 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and stop. You're gonna grab your playground ball or a cushion or a pillow, come back to the edge, hold that ball. You're gonna kick and twist to the same side. So let's take that left leg to kick out and twist it left. Here we go. Kick and twist. Kick and twist. Give me 8 more and 7. You got 6, 5, 4 before we switch to the opposite side. 3 and 2. And now right leg kicks. Twist to the right. Kick it out and twist. Keep going for 8 more. Like you're pushing something away. Keep it up. You've got 5 and 4 and 3, 2 and 1. Sit up nice and tall. Alternate your kicks. Kick out and out. Stay with me. Out and out. In 3 more, we're gonna add that ball, pressing overhead. In 2, keep it up. 1 more time. Let's press it overhead. Go up and up and up and up. 3 more sets. Keep it up. Final 2, energy is high. Stay with me 1 more time. Now hold those arms up. Keep your kick for 5 more sets. Arms reaching high, and 4. Really kick it out. Kick something. Imagine it's there. Here's 2. You've got this. 1 more time. And now bring that ball out straight in front. Shift your weight forward because I'm going to ask you to run across that finish line. You're holding that ball out. I want you to get those feet going with good control. You're running. Finish line is ahead of you. Keep going. Keep going. You've got 10 and 9. Really speed it up. Get faster and bigger. You have 6 and 5, 4, 3, 2. Arms up. You've crossed the finish line. Great job. Relax the ball down, but just slowly march your feet now so we can bring that heart rate back down. Take a nice deep breath in with me and exhale down. And again, nice deep breath and exhale to release. You're going to kick those heels out, alternating just like we started. You've done so much in between. Really good work. You got to keep that energy and that focus, especially when the arms get involved with those legs. Give me 2 more sets and 1 more before we take a deep breath in with arms reaching up overhead. Here we go. Take a deep breath in and exhale. 1 more time. Take a deep breath in and exhale. So why are these cardiovascular exercises important? Well, that's your fit tip, and that's because it improves endurance. And why is endurance important? Well, that gets you to be able to do more things during your day. So keep up your good work, and I'll see you next time. Take care.
All right, great. Thank you guys. We hope you all enjoyed that movement break and learned a few new exercises that you can do from the comfort of your home. At this time, we're going to begin our Q&A, so please feel free to continue submitting your questions for our online audience at the Q&A icon at the bottom black banner of your viewing page. Or for those of you in person, if you wrote a question on your paper, just go ahead and flag down one of our volunteers. They'll bring that up to us. We'll take the next 30 minutes or so to try and get to as many questions as we can. And as a reminder, if we are not able to, you can always contact our helpline at 1-800-4PD-INFO. So give me 1 second, I'll switch to some of our questions we have. All right, so Dr. Mari, someone from our online audience asked, what is considered a large or small amount of protein? A hard-boiled egg, 1 slice of turkey?
Thank you for that question. And just like I emphasized earlier, there is no one size fits all, and it particularly comes through in terms of quantities. So as far as the potential of proteins interfering with levodopa absorption, that too depends on the quantity. For instance, there are people who are very sensitive to levodopa, and they are taking as little as a half a tablet of the 25-100, say 4 times a day. And if that's all you're taking, and you take one full egg, that will probably cut the absorption in half, and that will be very significant for you. On the other hand, if somebody's taking a lot bigger amount, and let's say it's a bigger person, and they take, let's say, 300 milligrams of levodopa per dosing time, 1 egg is not going to be a tremendously big factor there. But besides just the body weight and the total amount of levodopa, how we look at the protein that is relevant is through experience. Because in terms of the gastric emptying, the person's sort of enzymatic activity to attack the proteins in the intestines, a lot of these factors are individually variable. So even in the same sized person, same weight, same amount of levodopa, it's perfectly possible that 1 egg will make a difference, and then another person, same everything, that egg will not make a difference. So it is something that we can sort of keep an eye on and consider and evaluate based on the clinical experiences, whether we think it's an interference or it's not. The other thing that I'd like to say that even there is an interference and the protein will certainly hold back some of the levodopa absorption, many times we can compensate that by just adding a little more. And certainly in the earlier stages of Parkinson's disease, as I explained, I'd rather do that than telling the patient to eat less protein, because it's a relatively easy compensation. It becomes less easy in the more advanced stages because not necessarily because there is something wrong with adding 100 more milligrams of levodopa, but why it's difficult is the unpredictability, that it will interfere, that one egg will interfere this much and one day and one dose of levodopa, but it will not be the case the next dose or next day. Something completely different could be seen, and that unpredictability is very hard to compensate by adjusting levodopa amounts.
Great, thank you. We had a question about medication timing. This person asked, I have heard that we shouldn't eat protein 1 hour before or 2 hours after taking Cinemet. Then I was told I could eat protein, but not in large quantities. What is your advice about medication timing when eating protein?
This is exactly why I spend that time and put that into the topic, because it is a very common experience. This question exemplifies that I get this all the time. So I make advice in the clinic to my patients about protein intake and timing, and they will tell me, but that's the opposite of what the other doctor told me out there. And so that's a very common experience, and that's why it's a controversy. So again, number one, we always have to individualize. There's no such thing that, I'm going to cut protein because I think that's a good thing. Maybe it's not applicable to you. If it is causing a problem, we will know and we will adjust, and how we adjust will be based on the experiences rather than some general rules. However, there are general rules, and again, the general rule of thumb is that in the early stages of Parkinson's disease, I would not restrict protein, I would not time it. It just adds another layer of concern and burden on you to now when am I going to take my levodopa? Oh no, I'm not going to take that shrimp salad now, so that's unnecessary. So in the early stages of Parkinson's disease, just don't worry about it at all. Now, as I mentioned in the main part of the talk, the disease progresses and you get to that point where you wear off, where you have to take more than 3 times a day dosing of levodopa. You may have motor fluctuations or no fluctuations. That's when protein intake and timing of it will matter. And exactly how it will matter, again, it depends on the individual, but generally speaking, trying to sort of shift your levodopa dosing to empty stomach and low protein intake in the daytime and the daytime only, and focusing or concentrating large protein meals to the end of the day is the general rule. So that's the general rule. But again, much more important than the general rule, we need to understand the individual. How, in some cases, I've seen very advanced patients who are fluctuating a lot, and it doesn't seem to make a difference whether they take the protein with levodopa, with empty stomach. It just doesn't seem to make a difference. Why? We don't know. And I also have seen patients on the other end of the spectrum. So rather than the general rule I described, more or less, in the context of the stages of Parkinson's disease, and especially with the presence of motor fluctuations versus no motor fluctuations. So that's the general rule. Besides the general rule, it is very individualized, and we have to observe the patient and make adjustments based on what we are seeing.
Great, thank you. So on the supplement slide, there was a reference to not taking iron supplements. Should we find a multivitamin that doesn't contain iron, or just don't take extra iron?
So one thing that unfortunately I have to say many times is that we don't have rock steady evidence, like a smoking gun level absolute knowledge on this. And the other rule that I keep repeating is that it's probably some patients you shouldn't take iron, whereas others you should, and we just don't know which ones. So my general approach is that extra iron probably, unless you are anemic, because that obviously will overrule that, probably unnecessary. The iron content from your multivitamin and your otherwise healthy and full diet should be sufficient.
Great, so that could lead into our next question from our audience. Multivitamins versus individual vitamins?
So again, it's a great idea for our next study, maybe. So we'll ask for funding for running a cohort, a prospective study on this question. I think multivitamins, for the most part, are put together with our best knowledge as to what vitamins and what quantities are needed for the body. So I would probably start from there. There's not much wrong with that. Now, as far as individually adding to that, again, without really hardcore evidence there, I would probably single out niacin, which I mentioned in the main talk, as part of the B vitamin complex, also known as B3. I personally would probably take that in addition to what the multivitamin complexes include. And there's not much to lose with that because vitamin B complex and vitamin C are water soluble. And to some extent, water soluble vitamins are hard to overdo because you pee them out. The excess, what the body doesn't need, does not accumulate somewhere. Whereas vitamin A or vitamin D, which are lipid soluble vitamins, there is such a thing that you could do too much of a good thing, and they can accumulate if you take too much of them. That doesn't happen often, but again, it's coming back to the excess or individual vitamins. I would probably add, if there is one that I would add in addition to the multivitamins, is B3.
Great, thank you. So someone from our online audience asks, should Parkinson's patients give up alcohol altogether?
That's another question I get asked quite a bit. And so there's a politically correct answer and there is a little bit more realistic answer. So of course, there are many studies that show that even if you drink a half a bottle of beer a day, that will lead to more neuronal loss than if you don't drink a half a bottle of beer. So if you base your advice on that, then yes, give up alcohol, absolutely. But then there is another sort of perspective here, which is that if that gives you a little, additional social context, a little, pleasure, adding to your quality of life to have a glass of wine with your spouse or in a social setting, taking that away poses some loss too. So which loss beats out the other? Again, no studies to resolve that question, but I generally say that I have a hard time believing that a very moderate, like one drink a day or a couple of drinks a week or something truly with moderation and truly just for the purpose of a social enhancement, how that could harm people. Certainly that much alcohol will not interfere with any of the medications that we prescribe. It was certainly not going to accelerate the Parkinson progression in any clinically meaningful manner. So my point is that our absolute alcohol ban, I don't see that advice very strongly justified. Having said that, don't overdo it. I mean, that's certainly something that I discuss with essential tremor patients who notice that their shaking is slowed down by alcohol. And so we have to tread this very carefully. Certainly, there are monoamine oxidase inhibitors that are not fully selective, and red wine tends to have a high content of tyramine. And so if you take selagiline, for instance, that is not entirely selective, so there could be a risk with a lot of red wine, but a glass or so is still okay every once in a while.
Great, happy to hear that. Is organic food better for preventing or helping to slow progression of PD, or can any diet prevent PD or slow progression?
What was the first question?
Is organic food better for preventing or helping to slow?
Organic food versus not. Okay, well, again, there's no evidence of that. I think the benefits of organic food have been established to some level, but as far as how it would be slowing down or preventing Parkinson's disease progression, there's no evidence whatsoever there. So I would certainly not pursue that in that regard.
Great, thank you. So we had somebody ask, is dairy bad for PD? Should I avoid milk?
Well, again, we're talking about protein there. Beyond the protein content, it doesn't really have any specific concerns unless you have lactose intolerance, which I have. I just found out about that too through 23andMe, and now I understand why I had this bad stomach when I was a kid all the time. But the bottom line is that besides the protein relevance, I don't see any issues with there for Parkinson's or for Parkinson medications.
That's a good transition to our next question. Do you know, is 23andMe still free for Parkinson's patients?
I don't believe so. I know PD generation is free, and they test for the same genes. Of course, 23andMe will test a whole lot more than just the PD genes, but I believe it's no longer free. I believe that in the future, and Dr. Roy Alcalay, who I mentioned earlier, a good friend of mine, is definitely a major promoter of this. Genetics will play more and more a role. So getting ahead of the game could be important in ways that we don't even see now. So for instance, if you had knowledge about your genetics, that you could line up to some research because you would be eligible for that we don't even recruit now, but it could just pop up tomorrow. And then you would be ahead of the game if that was the case. Also, if there were, gene-specific advice on nutrition, talking about nutrition or supplements or whatnot, and you already knew your genetic status, that could give you a leg up immediately getting on that advice. I mentioned earlier that there's no one advice fitting all, and how it's going to be different in different patients. We hope that this whole precision medicine idea will be heavily anchored on genetic information. So I'm a big promoter of that, and the PD generation is not only good for it being free and you can do it right away, but my understanding is that they're going to be adding more genes as knowledge becomes available, because the sample will be saved and will be testable for later.
Yeah, and as Dr. Mari mentioned, PD generation is free, so please feel free to chat with myself, Kayla. We also have collateral back on the table if you guys are interested. So our next question, Dr. Mari, how can I, as a care partner, help my person with Parkinson eat better? They don't want to eat healthy.
That's a tough one. That goes beyond just the nutrition science. This not only nutrition, but I get this a lot, that we tell the patient and their care partner what is the healthy living advice: exercise, drink a lot of fluids so that you're not dehydrated, eat healthy, etc. But that is a burden to the patient, and the patient is like, just leave me alone. This is how I enjoy my life. I have, the next 15 years to plan for, and I want to live it in a way that makes me happy. And it's the same sort of dilemma that I mentioned about the alcohol. And so there is always a healthy balance there. There are certain things that the care partner can do. First of all, as I mentioned earlier, a nutritionist consultation can be very helpful, because they can understand what is it that the patient wants. Why is it that the healthy foods are rejected or not liked? What taste they have? And work between those two endpoints and find a healthy compromise, because you would be surprised how many different things that we may not think of that are healthy, maybe not too expensive, and still will provide a pretty good culinary experience. And that would be my suggestion, to research that. So respect the patient's preference for certain tastes, for certain types of meals and ingredients, and find a way to use that understanding and sort of apply to healthy type of foods. And that oftentimes, you would be surprised, is possible.
Great, thank you. So from our in-person audience, we had the question, is taking CBD beneficial or non-beneficial to relieve Parkinson's symptoms?
Wow, so that's the next hour. We're going to discuss CBD. This is obviously a very common question that comes up. I sometimes tell my trainees who shadow me in clinic that just count the number of patients who won't ask about medical marijuana, because there are not too many of those. So the bottom line is that just like with everything else, we don't have beyond consensus, very established knowledge on the topic. We actually had a medical marijuana conference here in 2000, I think either 17 or 18, where we had a patient panel sitting up here, patients sharing their own experiences, and personal experiences are very important. Many patients will say that it helped the tremor, it helped the dyskinesias, that's a common one, it helped the sleep, helped pain. So all over the map, which one is it? At the same time, you will find a lot of patients who said it did nothing for me. And so that's why we are still kind of wondering as to what we should study. And one problem is that there are so many different entourages in medical marijuana and CBD in terms of how you isolate it, in what form, what dose. So there are more questions than answers for sure. Now, my general advice is that, well, first of all, I can't recommend it. That's the Cleveland Clinic rule. I can't tell you how often, which dose, which formulation, etc. I don't have that knowledge. But if patients tell me that they have tried it and it helped them with their sleep, with the pain, with the tremor, with the dyskinesia, or whichever symptom that matters to them, I will not tell them to stop it. So it is with my blessing, and I don't encourage anyone to try things that we don't, have medically proven evidence. But at the same time, I do realize that patients want to get better and they want to have an open mind and try things that are not formally recommended by their doctor. And if they score a hit, then I say go with it. At the same time, I also wanted to warn about some potential downsides. So first of all, it's not as well regulated as medications. We discussed that earlier. Second, many medical marijuana products that are advertised as CBD may also contain other compounds in there, including THC. And we have so as much as we don't know a whole lot about CBD, and it may help for certain things, and it's probably not harmful. THC is harmful, and that's a psychotropic compound, which can derail many things about your Parkinson's disease, especially in the non-motor domain. It can interfere with medications. It can be addictive. So there's a lot of problems concerning THC. So I just wanted to make sure that we discuss that too.
Great, thank you for sharing. I'm trying to manage another condition that requires a special diet. Any advice for those of us with comorbidities?
Exactly, and when I was on my first or second slide discussing the fundamentals, I mentioned that besides Parkinson's disease, living healthy and eating healthy is just good for anyone, whether or not you have Parkinson's disease. And the comorbidities are always taking precedence. So if you have high cholesterol or other form of hyperlipidemia, if you have hypertension, if you have diabetes, all of these comorbidities have much more established and clear nutritional and dieting advice and requirements than Parkinson's disease. And therefore, that will always be superior to whatever we think or say at this time. We would try to combine the two things. I mean, it's not like they are drastically different advices. I mean, if you are eating healthy and consistent with your diabetes, that will not harm your Parkinson's. But as much as for Parkinson's, there's more leeway and we don't know everything, it is very clear that for these comorbidities, if you don't follow the diet, then that's going to hurt you. So in other words, it is very important to follow that regardless of your Parkinson's. And then in terms of what may be modified or need to be taken into account because of your Parkinson's, that has to be done individually with your treating physician.
Great, thank you. So someone online asked, my loved one has trouble swallowing. Is that a Parkinson's symptom? And what can I do to make sure they get the right nutrition?
It is definitely a Parkinson's symptom, and it's a common one to the point where it's part of any standard questionnaire. We use the Unified Parkinson's Disease Rating Scale, or the Movement Disorder Society version of it, the MDS-UPDRS, and a question about swallowing is part of that standard questionnaire because it is a common problem in Parkinson's disease. It's usually seen in more advanced stages of Parkinson's disease. Now, how that is taken into account, again, depends on how the severity of the dysphagia or swallowing problem. There are certain medications that are available in patch form or formulation, and both dopamine agonist as well as cognitive medications such as Exelon. And so for the ability to use these different necessary medications in a non-swallowable or non-pill format, we do that. There are also other measures, and there's swallowing exercises that can be utilized. And of course, it's very important to always monitor and assess the degree of swallowing problem to identify safety issues. Because if it's no longer safe to swallow and patients have aspiration experiences, that puts them at risk for aspiration pneumonia. And every infection in Parkinson's disease is 10 times more dangerous than in a non-Parkinsonian individual, because one thing that happens inside your body with Parkinson's disease, that the body's own internal warning signaling system is down. So you don't necessarily detect when you are limping towards sepsis, when the bacteria are just streaming the blood, because normal people have a high interferon spike and other signaling that they know something is really wrong, the fever goes up, and those internal signaling issues are down. So we are very nervous about infections. So there's a pretty high attention to swallowing problems because of that. Now, of course, if somebody is beyond the point where swallowing exercises and patches and other workarounds are practicable and feasible anymore, then you will have to sort of get through the point of pack feeds and delivery of medications. It's a huge step. It will be difficult psychologically, but it's necessary for safety. And a lot of patients live with PEG happily ever after, and medications can be pulverized. And of course, the feeding can be even more standardized through the tube feeds.
Great, thank you. So we had somebody ask, they said, I was told to avoid too much grapefruit with my cholesterol medication. Are there any PD medications that interact with food that should be avoided?
Grapefruit, yeah. So grapefruit comes on every label. If you open up a random medication box and you take out that fine print label in there, you will surely find grapefruit somewhere in there. So I wonder why, but I certainly don't see that in my experience with Parkinson medications, and I don't ban grapefruit. I have not seen any study or other evidence or personal experience that would support that. At the same time, what other foods can be avoided? Well, I mentioned tyramine earlier, which in the context of drinking alcohol, but certainly in the amount of tyramine that's in red wine, you would have to drink a case to interfere with the relatively selective MAOB inhibitors that we prescribe now. On the other hand, there's more tyramine in aged cheeses. And so if somebody's, so there are 3 currently used MAOB inhibitors. The oldest one, selagelin, which was discovered by a Hungarian scientist, Joseph Knoll, is the least used one, and that's because it's the least super selective to dopamine. So the concern about tyramine is that if the selectivity of the MAOB is not perfect, then it will block the breakdown of other monoamines, including serotonin and tyramine, and that can cause this reaction, this serotonin type reaction. Now, the other 2 currently used MAOB inhibitors, rasagiline and cephinamide, then their brand names are Asilact and Xadago. Those are super selective. So people say, don't worry about dietary restrictions on high tyramine foods, but I still say, well, don't eat like a pound of aged cheese anyway, because aged cheeses are the ones that are relatively high in tyramine content. Now, besides that, I mean, we discussed the protein to a great deal, and that's something to keep in mind.
Great. So speaking of, is there a ratio you recommend? How much protein to how many carbs?
No, I don't have a number like that. I say that just eat as much protein as you can, with a very high protein, especially in advanced stages of Parkinson's disease towards the end of the day. You can't go wrong with that. As far as carbs, losing weight is a common problem in Parkinson's disease. Having said that, I had many patients who were overweight. So this is something that is highly customizable, or to be customized and individualized, because everybody is different. I see a lot of patients who are underweight, and I say, eat ice cream. Ice cream is good, I don't want more weight loss. Patients sometimes are dyskinetic, and dyskinesias, while it's actually good for the joints and the musculoskeletal system that they are being worked at all times, they are bad in terms of patients losing weight because it's burning calories all the time. So in that case, I say, carbs, fine, ice cream, good. Just make sure that you're not losing weight. Now, there is no ratio, but you can't just eat tons of protein and cover all your calorie needs from protein. It's obviously not pleasant. But to the extent that's possible, more protein is better, with those rules that I discussed earlier, that if you are wearing off and motor fluctuations, then try to not time that along with the timing of your levodopa in the daytime only.
Great, thank you. So it does look like we only have a couple of questions left. If anybody has one you want to submit, please send that up here. So Dr. Mari, does exercise impact medication absorption? Does exercise impact medication absorption? Should I time my medications with my daily exercise?
This is an excellent question, and the short answer is that yes, it does impact it. And the way it impacts it is that when it's a meaningful exercise, and playing chess or getting a beer from the fridge, that's not an exercise. The meaningful exercise to me is when you break a sweat. And so when you're talking about meaningful exercise, that will necessarily lead to adrenaline release and sympathetic activation. That's how our body works. This is the fight or flight reaction. And when adrenaline is released and the sympathetic nervous system is activated, that means a rearrangement of the blood flow across your body. Muscles will get more flow, the brain gets a little bit more flow, certain organs will get more flow, but certainly the gut, which otherwise holds a large amount of blood, will get less. So the blood vessels will constrict in the gut, and it will lead to a little bit of slowing down of the peristalsis, to the point when there's a lot of adrenaline, the gastric emptying can actually shut down completely. So in other words, both the stomach and the intestines are not moving as much. There's less blood flow and perfusion through those areas and GI systems. So that could lead to, obviously, a delayed or reduced absorption of medication. Now, how big is that effect? Well, again, it varies very much by the individual, and also varies as to how much of the exercise we are talking about. If you heavily work out for a whole hour, that almost certainly will have a clinically meaningful impact on the absorption of levodopa that you just took, or was still in the stomach when you started exercising. On the other hand, the 15 minutes on like a reclining bicycle and barely breaking a sweat, and your medication was taken already 2 hours before that, it's probably not going to be relevant. But as to how much it is relevant, again, could vary from one person to another, and we sort of try to determine that based on the experiences. So if you work out and you notice that once you took the medication and you worked out and it didn't work as much, we nailed that one. It's probably the cause, but it doesn't necessarily happen to everybody.
Great, thank you. So for our last question, can a healthy diet like MIND or DASH help with non-motor symptoms like depression or cognition changes?
Well, it certainly won't hurt. As to whether it will help, we don't know. There is no such specific study. Having said that, eating healthy, which is hopefully good for the brain and the body, will maybe mitigate the stress which will worsen non-motor symptoms such as anxiety and panic attacks and bad sleep, etc. So while I don't have hard data to prove it, I say that probably does help.
Great. Well, thank you, Dr. Mari. That does conclude our Q&A session. So thank you again for taking the time to answer questions from our audience. I think Dr. Mari will be sticking around for a little bit, so you may be able to catch him if we didn't have time to get to one of your questions. So again, thank you. I do have a few more slides if you guys could just stay with me for a couple minutes. Before we go, I'd like to give a huge thank you to our sponsors, Supernus, Boston Scientific, MERS Therapeutics, Kiowa Kirin, AbbVie, and Medtronic. Without your support, these programs would not be possible. Again, please stop by and visit their booths if you haven't yet. We hope you'll come back soon and join us for more of our programs. You can join us virtually for Mindfulness Mondays, Wellness Wednesdays, and Fitness Fridays every week through PD Health at Home. Coming up in the Southwest, we have a busy schedule of community events and educational programs. I know we have a few folks in person joining us from Albuquerque, and on June 11th, we'll be hosting Parkinson's Sleep in Me. This program is in person only and registration is limited, so please come chat with me or online, click the links to learn more. We also invite you to join us for 2 exciting community events, Parkinson's Revolution, an indoor cycling event, and Moving Day, an inspiring and empowering fundraise walk. You can join us in person if we're in a city near you, or virtually. You can learn more by coming to chat with us again or clicking the links in the chat. If we were unable to get to your question today, I encourage you to contact our helpline at 1-800-4PD-INFO, where our Parkinson's specialist would be more than happy to hear from you. Today's sessions has been recorded and will be available for viewing at our Parkinson's Foundation YouTube channel. For those of you online, as our program concludes, we ask you to complete an evaluation of today's program. For those of you in person, you will find an evaluation inside of the folders provided. We appreciate your feedback as we use this to plan future programs. A link will be sent to all of you in person and online that will include the recording, resources we shared, and the evaluation link if you have not completed it already. On behalf of the Parkinson's Foundation, thank you for joining us. Stay well and come back soon.